Thank you everyone for joining us for another Learning Lunch hosted by formatapproved.com. My name is Brian Johnson. I'm the Senior Director of Online Training and Education at Format Approved, and I'll be your moderator today. Today's Learning Lunch will cover ICD-10 prep for non-acute care practices. We are joined today by Kristen Heffernan of Henry Schein MicroMD. Kristen is an expert in practice management and EHR software who's going to share her expertise on ICD-10 CM with us today. She's going to provide a higher level review of some of the information practices need to tackle the conversion from ICD-9 to ICD-10. It's our pleasure to share her expertise with you. First, some quick housekeeping notes. Note that you can ask questions of our presenter at any time during today's session by entering them into the chat area during the presentation. In the second half of our session, we will address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent by email link later in the week. Also, note that all registered attendees of today's session will receive an email with links to both the recorded and PDF versions of the event. So if you're looking to get the slides after this session is complete, rest assured that we'll send those out to you shortly. Well, Kristen, thank you for joining us today.
Sure. Glad to be here. I'm glad everybody else was able to join.
All right. Well, there's so much interest in ICD-10 now with the conversion coming. So let's get right down to it. First of all, for anyone who doesn't know, what is the official definition of ICD-10?
And let me start off by saying, while there's a couple of things that I have good expertise in because we consistently work with our clients, especially now, all of our clients, because we are a PM and EMR vendor, want to know when will our systems be ready, how can they test, and how does it connect with other systems that will be impacted by ICD-10. So one of the things that I'm doing right now is putting together some of these educational sessions at a high level to kind of roll out and set the expectations for our clients of what they should be doing and planning for today as part of ICD-10. So while I don't profess to be a professional coder, a professional biller, or a doctor, nor do I play one on TV, where I do have the expertise is at this high level to talk about what is ICD-10 at a high level and how providers and their staff should be planning for this transition. So to answer your question in a very specific way about the official definition for ICD-10, this will be one of the few things that I will read word for word because I want to make sure that everybody gets this right and keeps it straight in terms of what is ICD-10. And first off, ultimately it is the World Health Organization, or the WHO, that publishes the ICD code set. And that code set defines diseases, signs, symptoms, abnormal findings, complaints, and other things, as well as external causes for injury or disease. And ultimately, the WHO creates this large ICD-10 or ICD code set, and then the U.S. is actually authorized to adapt the WHO's code set and use it for government purposes. So what now gets broken down from that larger WHO code set is the United States currently working off of the 9th edition of that code set, which has been in place since 1977. And what they're doing is essentially updating that to create these two new ICD-10 code sets, broken out into ICD-9, clinical modification, or the CM, which is typically used in all healthcare settings. And then the second piece of that is the ICD-10 PCS, which is the procedural coding system. And that's really more used in inpatient hospital settings, things of that nature. And then if we break it down a little bit further and we go into the specific definition of what the clinical modification set is versus the procedural coding system, the ICD-10 CM, essentially it is the clinical modification of the WHO's ICD-10, so the U.S. has adapted that, and it consists of diagnostics, classifications, And it really, what it does is includes the level of detail needed that documents morbidity classification and diagnostics within the United States. And that code set, that system, the CM system piece of it, clinical modification, has about more than 68,000 diagnosis codes in it. And
well,
then if you take,
I was going to say, I know we're going to get into the details more in a moment, but that's quite an increase in the number of codes over ICD-9, so I know that's one of the reasons why people are concerned. Please continue.
Absolutely. And the flip side is you have the ICD-10 PCS, the procedural coding system, again used more in acute care settings and hospital-based settings, and they're also seeing a jump in the number of codes, the procedure codes. So that piece is really dedicated to the details and specifics for procedure codes. It's much more detailed than ICD-9. There's a number of additional codes, obviously, that have been added to jump that number to 87,000 codes. So that's where we stand with ICD-10 versus ICD-9 definition at a high level.
So given that there's so much complexity involved, why is this switch to ICD-10 happening now?
So, and there's a number of different reasons that this change is occurring, and many of them are, they're broken out into 3 different areas. It's, the ICD-9 code set is just outdated. It's been in place since 1977. There needs to be more flexibility. It's a 30-year-old code set. It's very limited in terms of the medical terminology that it covers. There's been so many changes in medical terminology over the years that aren't accommodated by the ICD-9 code set. The ICD-9 code set is very limited in terms of numbers. They're starting to actually run out of space for new codes in some areas. The ICD-9 code set also doesn't capture the level of detail and specificity that payers are requiring, that CMS is requiring, and that the industry, the healthcare industry, is requiring as a whole to be able to document such things as differentiation of risk and severity, which parameters that are used to differentiate disease manifestations, data included with the codes that would help optimize claim reimbursement. So there's a lot of different things that they want to build into the essentially it's additional data that gets tied to the ICD-10 codes. Some other reasons that the code set is being implemented is really for the payer side, and realistically so that payers have more data to be able to analyze claims for how healthcare is being utilized, better data for analyzing costs and outcomes, realistically better data for the payers to be able to optimize their use of resources, as well as providers as well, and be able to measure their performance and how they're doing as payers. And again, I talked about optimizing claim reimbursement. And then you have the overall good things that we want to happen absolutely for everyone, which is better healthcare operations, better outcomes, assisting providers in streamlining payment operations, so making sure that all the data is included with the code so it can, there's a better streamline of how that works, increased automation, so it's essentially submitting your claims, having the things go through, not having a lot of back and forth on those claims to add additional detail or specificity to approve or deny claims. So improving some of those processes, minimizing provider and patient inquiries, speeding it up, so trying to reduce the delays and reduce denials. And then updating the medical terminology, again, is a big piece, and that's something that we'll talk about on the training side in terms of what are some of the new things that coders, billers, front desk staff, and clinicians will have to pay attention to in terms of what's coming down the pike for ICD-10.
So let's get into some of the unrealistic expectations, or maybe we should call them fantasies, people may have about how the transition's going to happen. And the first one is one that I want to address or ask you about, especially because I hear it from time to time, and that's that a lot of people CMS has pushed back the date before, and a lot of people seem to really be hoping that CMS is just going to say, you know what, we're going to do it in 2015. Can you address that and some of the other unrealistic expectations people may have?
Sure, and you hit the nail on the head with the first one being CMS will change the date again. And I stress the term again because this ICD-10 was mandated to go into effect in October of 2013. And last year, I think around January, February, they had announced that they would indeed delay it until October of 2014. So it did give everybody a little bit of breathing room, but it was intended to give some breathing room so that providers, payers, PM and EMR vendors, anybody that's connected to ICD-10 codes would have time to now really get moving and start planning for the transition. You'll see a lot of back and forth with the AMA and CMS and the ONC about whether or not, the AMA being completely opposed to the implementation date of October 1st, 2014. The reality is, and you'll see it all over the place, CMS clearly states the date will not change. So that's what we should all be planning for, is that the date indeed will be October 1st, 2014, that providers need to be submitting their claims in an ICD-10 format. So that's very important. Another, and when I say unrealistic expectations, these are all things that as we talk to clients and we talk to other vendors and partners within our industry, this is what we hear. We hear these, oh, we have plenty of time to prepare. Oh, the vendors will take care of the transition for us. Oh, this really only impacts the coding side. The reality with these things is that while it seems like October 1st, 2014 is a long way off, the reality is when we start getting into some of the items that you need to be planning for in terms of different tasks to make sure that you can meet that transition date, you'll understand why you should be planning now and why we recommend that wholeheartedly. Keeping in mind that anything that's touched by an ICD-10 code will have to make some transitions and do planning and maybe reprogram software or tools that providers use, program interfaces, things of that nature. So it's not that the vendors will be handling the transition for the providers. It's really the provider's duty to make sure that they understand how the changes will impact their own practice, their own internal and external systems, their staff, their policies and procedures, and what training will be required in order to make sure that they are doing, the providers are doing what they need to be doing on their end, and relying on their vendors to, communicate what the vendors will be doing and when, and what the providers should expect in working with each of their different external system vendors, when the training might go into place and all of those things. One of the biggest challenges that we hear from people are that it really only affects coding. The interesting thing with ICD-10 is that not only does it impact coding, but it really does have a major impact on the clinical side in terms of increased specificity and documentation for patient encounters, and making sure that all of that documentation is there so that the codes can be properly assigned based on that level of documentation. So it's not just learning a new set of codes, it's a matter of making sure that the clinicians know exactly what needs to be documented for each patient that they see, for each situation. And the doctors need to know what's required of them. The practices also need to be going to their payers to make sure that they understand by payer if there's any differences in what might be required for each diagnosis code, to be able to assign each diagnosis code. So another final unrealistic expectation that I like to share with people is that assuming that all the external stakeholders will get this right. Everybody that's lived and breathed through 5010 and that transition knows that not everything was perfect. And CMS did give a little leeway once 5010 went into effect. It was like a 90-day breathing period where they weren't going to be auditing, just to make sure that all the payers got it right, all the different software vendors got it right, and the providers got that the new billing process right. So that was a challenge. ICD-10 will have some of the same challenges. It's just more interesting on the ICD-10 side because there are so many more moving parts. 5010 really just impacted truly the billing side of the business. We're looking at ICD-10, which impacts every area of the practice.
So it sounds like there's a lot of need for planning and training, which I know we're going to get into a little bit here in a minute. But let's first of all talk about the coding set itself and how it's changed. So we've got to assume that our audience knows a little bit about ICD-9, or they probably wouldn't be in on this learning lunch.
Sure.
But ICD-10, how is it different then from ICD-9?
And again, keeping in mind that most of the people on the call are way more knowledgeable about the actual ICD-9 code set and probably even how those changes occur to ICD-10. But for folks that are really starting to get their feet wet and really starting to understand what the differences are, this is the high-level description is essentially that the field length is changing from a max of 5 characters with ICD-10 or ICD-9 to a max of 7 characters with ICD-10. And it will be a combination of different alphanumeric digits in each of those places. So it really does allow for more flexibility, additional codes, and adding the codes. Now the code set in general, if we're again talking about the CM code set, which is really more applicable on the diagnosis code set side to the providers, is that the code set goes from anywhere from 13,000 to about 68,000. But the thing to keep in mind is not every provider, not every code is going to be used. Even though the code sets jump to 68,000, a practice still uses a same common set of codes over and over and over, typically within their practice or within their specialty if they have multiple specialties within the practice. So it's not, you should kind of step back for a second and go, well, I don't have to know all 68,000, but you do need to know the changes for the codes that you commonly do so that you're able to make that transition. And then, as I mentioned, the code composition changes a little bit about where the digits sit. There is available space for additional codes, and there will be way more detail included in the ICD-10 codes, and that's one of the keys as to why there's such a change in the size of code from 5 to 7, the makeup of the code, and then where different things sit. And what I wanted to touch on, and then if Brian can advance our next slide, is to go through a coding example. And this example that you're seeing on the screen, I pulled from AAPC, and AAPC is a great resource if anybody is looking for some of these different samples for ICD-10 coding, to be able to take a look at it, dissect it, pick it apart, and kind of get a sense for how the different codes are laid out alphanumerically, the level of detail that's now included, that needs to be included in the actual diagnostic information, and then how that actually gets translated into a code. And this is just a very simple example. And again, I don't profess to be a professional coder, so I do rely on AAPC to give me a little bit of direction here. But one of the first items that you'll see with this particular example is, again, at the top is the description of the encounter and what is occurring. So you have Mrs. Finley that came into the office after having a cabinet fall on her last week. So that piece ties back to external cause. And if you're looking down the left-hand side of this slide, we'll cover these 7 areas that are outlined in the new ICD-10 code. So these are some things providers may have been documenting already. Some of these things might be new. But again, it's very important to understand that if you're going to translate what's been documented into an ICD-10 code, you have to have all of the correct information within the documentation. So being able, in this particular case, to document external cause, and that being the fact that the cabinet caused the injury, so description of the cause is required for documentation here, and then also being able to document the actual activity. So what was that patient doing when the injury occurred? And that has to be documented for the initial encounter so that you're able to assign an activity code. So Mrs. Finley was cooking dinner at the home she shares with her husband. The next item would be an example of having a 7th character. So again, ICD-10 maxes out, or ICD-9 maxes out at 5 characters. ICD-10 is maxing out at 10. And often that 7th character is used as an extender to in injury codes that essentially identifies the encounter. So making sure that there is clear documentation so that the correct extender can be applied in this particular case.
So to give an example, I'm sorry, to give an example, this is the initial encounter, so that's the A at the end of that code, whereas if it was a subsequent encounter, it would be another letter to signify that.
Or not even include that extra letter. Yes,
okay.
You're absolutely right. So that 7th character in this particular case indicates that she did not seek treatment at the time of the actual injury. She's actually coming in for her initial encounter, but she didn't seek treatment at the time. Another area of specificity that needs to be included in the documentation in order to code appropriately would be location. And you're hearing a lot of different rumors about how specific that location is going to get. And the reality is it probably will. There are, in most cases, you are going to need to have to specify whether or not the injury occurred on a set of stairs. Were they the front stairs, back stairs, internal, external? Did it happen in what room of the house did it occur in? So those are different things that, again, you need to be able to identify the ICD-9 codes that you typically use, which ICD-10 codes would translate, would those old ICD-9 codes translate to, and then understand what level of detail and specificity needs to be included in the documentation to know, to be able to code in the new ICD-10 world. So location in this particular case, the injury occurred in Mrs. Finley's kitchen. The ability to document applied specificity, because this is a concussion injury. In this particular case, you must indicate whether or not the patient lost consciousness. So in this particular case, Mrs. Finley's husband stated that she was out cold for about 2 minutes. That's a little scary. Glad that hopefully she's okay. And then being able to also document whether there was relief or no relief for whatever treatment she initially sought, whether that was an ice pack or whatever was occurring in that particular case. And in Mrs. Finley's case, being able to document that the headache came on suddenly and it did last for long periods of time every day that was not relieved by Advil. So there was no relief in this particular case for whatever remedy that Mrs. Finley took. So that needs to be documented. And then the last piece in this particular case is being able to document whether this is an acute versus a chronic injury. So documenting that as part of the patient's condition. So again, I don't profess to be a professional coder. This is a nice, simple example that includes a lot of the different specificity that will now need to be included in documentation, as well as how it gets translated into the actual numeric CM coding. So AAPC is a good resource. They actually have a little code translator tool on their website that you could refer to as well.
Well, thank you for that run-through of that example. So when we're talking about this transition, what all is going to be impacted by it? You said before that it's about a lot more than just coding. Give us some, maybe describe some of what we're looking at here in terms of how it's going to impact so many different things.
And again, this isn't meant to scare people. This is really meant to give providers and staff an idea of what they can expect. What are all the different types of things that they should be looking for within their practice that will be touched by ICD-10, or that's typically touched by ICD-9, and that will be touched by ICD-10, because those are all things that have to move forward in this transition. Those are all things that need to have changes planned for. And when we say what will ICD-10 impact, the response I typically use is everything but the kitchen sink. being able to take a look at every internal system, every process, every external system that you use, such as your PM and EMR, your billing company, or if you use a revenue cycle management company, or if you do all of your billing and payment in-house. How do you manage your super bills? Where, you really should be looking for, again, the key is to look for anything within your practice or outside of your practice that touches you, that is touched by ICD-9 codes and that will be touched by ICD-10 codes. So, a lot of people may not be thinking through, for instance, because this touches not only the coding and billing side, it touches the clinical side, knowing that now your EMR becomes very important in this particular case. And EMR vendors, and as well as practice management vendors, will be programming their systems to work with the ICD-10 transition, and keeping in mind that there will be some practices that have interfaces with lab companies, and the labs will require ICD-10 coding. Clearinghouses that you might work with will require ICD-10 coding. So you need to make sure that all of those things, different types of things, are accounted for. EMR, and the EMR side, your forms, your templates, how the documentation will change. So your EMR vendor will be programming new fields within the EMR to assist providers in capturing that additional level of detail in their documentation. Do you need to upgrade your hardware? If you will, you have external systems that you will need to upgrade, you may need to consider that there could be a hardware upgrade in order to meet any current requirements for software that you run within your practice. Being able to look at all your internal forms, looking at your patient registration processes, how you do referrals and authorizations, super bills, any eligibility forms that utilize ICD-10, or your eligibility checking that you may have through your clearinghouse. How are you doing admission scheduling if you're helping to admit a patient into a hospital situation, if that's the case? Any physician orders that you do, labs, tests, diagnostics that need to be ordered with ICD-10 coding and that will come back with ICD-10 coding in the form of different reports. And anything within your different softwares or within your practice, if you do any manual reporting, anything that pulls an ICD-10 code or features one obviously would need to be updated. And, little things that you might not think about, do you need ICD-10 coding to include a patient within a research study? Will you need to update ICD-10 codes to enable your public health reporting if you do that? How will your financial areas of your practice, your billing service contracts, your accounts payable, your cash flow, how will all those things be impacted? How will your payer relationships be impacted? So will contracts change? Will reimbursement models be different? Will you be required to, again, submit additional specific detail along with the codes to ensure that the required documentation is there to support the billing and get those payments issued? So a lot of different moving parts in terms of what ICD-10 can impact. And keep in mind that this is not an all-inclusive list. It really should be part of your process to perform an impact assessment, and we'll talk a little bit about what that is coming up. But taking a look at essentially everything ICD-10 touches and make sure that you have a good idea of that.
So what should providers do today to start to get ready for this?
Start planning today, absolutely. And I'm not saying that you will be able to do and execute everything today, but at least the planning process. So making sure, and even stepping back further, first and foremost, everybody needs to be submitting version 5010 for their electronic claims. For any electronic healthcare transactions, 5010 needs to be done first. And there's not many organizations that we've encountered that are still using 4010, but there are some folks that have a clearinghouse that they work with that have said, oh, well, we'll convert your 50-10 for you. You're not going to be able to rely on that anymore because your clearinghouses are really going to be in the place where they're going to need to be assisting you in transitioning your ICD-9 stuff to ICD-10. So they will not be as concerned as making sure that you're 50-10 compliant. So you should be making sure that you are yourself 50-10 compliant first. And then the next big thing is get people involved within your practice to start your planning process. So create awareness of how important this change is and create awareness with everybody of how many different areas that ICD-10 will touch within and outside of your organization. And then get everybody's buy-in. So share that information with the people that are going to be impacted by it and make sure that you have the buy-in from your key stakeholders, your physician owners or your solo doctor that runs the practice, or if you have a medical service organization that you work with, making sure that everybody's on board for this. And then very importantly as well, as you start planning for the project, you want to identify the people that are going to assist you in leading the project. So who are those people? And really you should bring together a good, you can't include everybody because too many people, how do they put it, too many people cooking the soup spoil the broth. You need to have very limited number of people on your team, but making sure that you're picking the people that are dedicated, enthusiastic, understand the importance of the ICD-10 change, and who also represent the different key areas within the practice that are going to be able to come together as a team and plan for all of the different impacts. So having somebody from the administrative side, billing, coding, front desk, having somebody from the clinical side. So do you have a physician and a nurse practitioner, or is it just a physician? And then also identify who your vendor contacts are, because they will also be part of your team as well within the different vendors that you work with, that you'll need to understand their plans and coordinate testing with them and make sure that everything's ultimately ready for go live. And then you want to start doing an impact assessment and then ultimately create your project plan. And your impact assessment is kind of going back to what ICD-10 touch and identifying all of those areas and documenting that, getting it written down. And from that impact assessment, then you can start actually creating a formal project plan.
All right, so what goes into creating an ICD project plan then?
Quite a bit. So as you see, and again, I won't necessarily go through every detail for every one of these items, but there are some key areas that we tend to focus on when we're working with clients to assist them in planning for ICD-10 when they call in and say, well, what is MicroMD's plan for making sure that your clients are ready for ICD-10? Some of the things that we initially talk about, again, is identifying those project champions and stakeholders. Who are the people that are impacted by it that will be helping to plan the project plan, complete the impact assessment, and then develop the formal project plan. And the key items to do in developing the formal project plan is, and most businesses do this with any large project that they have, is first identifying the milestones. So what are those large, high-level areas that you want to accomplish? So you want to engage your stakeholders. That can be a milestone. Conduct your impact assessment. Identify all of your tasks. That can be a milestone. And then take each task. Each major task can be its own milestone because each task may have multiple people and multiple things that need to be done to achieve a particular task by a certain time. You want to maybe identify testing, training, go live, and then post-go live could also be milestones that you might want to put on your project plan. And again, these are the kind of the big, if you look at it almost as creating an outline, these would be your Roman numerals, your one, your II, and your III. And then you start filling in your different tasks within each of the milestones that will help you achieve and reach those milestones. So what are all the different things that need to happen and by who and when and how much will it cost to achieve one of those particular milestones. And you'll start filling that in for each of your milestones. Another big area of project planning, and this is also very important with ICD-10 because it does impact so many things, is taking the time to identify and plan for risks. And some of that is kind of sitting down and playing devil's advocate and being a little bit little negative and saying, how can this fail? And at least identifying where are different areas that the ICD-10 transition could fail, either internally or externally. And the reason for doing that is so that you can plan for how not to fail. How do you mitigate those risks? So some of the things that you could have challenges with in terms of risks would be inadequate training, making sure your front desk is trained up, your clinicians, your coders understand the new coding. They understand medical terminology more than they ever have before because of the level of specificity that's required in documentation. There will be a lot more translation and understanding of medical terminology needed by coders. Another area that you might want to plan for in terms of risks is, external systems preparation, whether that be your vendors, your payers, your lab companies, whoever. You can never be sure that everybody's going to get it right at the exact same time. So making sure that you know when your code set's going to be available in your practice management system and in your EMR and how it will be maintained. Checking with your clearinghouses, make sure you understand what their timeline is. Checking with any organization or vendor where you might have an interface into your PM or EMR that would require ICD-10 codes. And make sure that you're working with your vendors to schedule training, schedule any upgrades, which everybody that needs has a PM and EMR system will need to schedule an upgrade with their PM or EMR vendor, or that your vendor might be able to do that remotely if it's not a big deal. And then schedule the testing, schedule go-live timing, and then understand what the different vendors have in place for ongoing support. Another area of risk that we like to talk about, a couple areas, is potential loss of staff. So, are people going to get out of the business now that they have to learn ICD-10? Or will you spend time training people in ICD-10 only to have them leave? So those are some things to consider, but you still need to be moving forward. And look at budget limitations. Do you have, and look at that from a number of different sides. Do you need to purchase new hardware for some reason? Is there a cost to your upgrade? Would you need to be purchasing training, purchasing consulting resources, or different tools that might add on to your PM and or EMR software that will assist you with mapping your codes over? So knowing that you might need to budget for those sorts of things and those changes, and any negative impacts that may occur with payer or patient relations, understanding that there will be a lot of phone calls and a lot of back and forth and probably increased denials or slow payments that occur as a result of the transition to ICD-10. So you're going to get more phone calls from your patients, and you're going to be making more phone calls out to your payers as well. And a big piece is on the reimbursement side, is that setting the expectation that revenue may not come in the same way and as quickly that it has in the past, because again, you're dealing with multiple payers, you're dealing with multiple systems. Not everybody is necessarily going to get this right. So understanding that there could be a reduction or slowing in the revenue stream with payers not being ready or inaccurate coding, maybe on the coding side, or disputes back and forth between the two. There could be an increase in denials or payment delays in situations where there is a fee-for-service billing, or in alternate reimbursement models, because some of those still have kinks, like the ACO model and case-based models. Each of the payers will be looking at those and saying, okay, how does this change in the ICD-10 world? So there could be some additional challenges there. And then just keeping in mind that there could be increased audits from the payers who want to make sure that everybody's on board with doing the right things. So that's something to keep in mind in terms of reimbursement challenges once you actually go live. On the risk side, making sure that the positive piece is you're planning for those risks so that you can plan for how to mitigate those, how to address them. So make sure that you have a way for staff and everyone to report issues, and you have a decision-making chain in place to address issues and resolve those quickly, and then plan through what some of the resolution processes might be in certain common challenges that you might have. So those are very important in terms of planning for risks with your project. Another thing with the project plan is once you have your tasks and your risks identified, add a timeline to your project. So, starting today, your first milestone is identifying your milestones. So put a date to that. Say you want to identify your milestones by next week, and put a date by that. And then for each of your milestones, put a major date attached to those. And then as you fill in your tasks, put dates in there for your tasks as well. But you want to make sure that you're realistic about your timing, and put realistic dates behind those. And then set a budget. So do you need to have additional funding either before your transition, or do you need to have money available after go live? So you need to have a cash reserve maybe available to overcome for slow payment or denied reimbursements or things like that that might impact your cash flow. Very, very important when you're working through these project plans is to communicate it. Number one, when the project plan's done, share it with people that are impacted by it. And as you start working through your project plan and picking off those different tasks over time, you're sharing with people the accomplishments, and you're sharing the failures as well. So, the good and the bad. So everybody's in the loop. Everybody knows what's going on, and they know where you are in terms of being ready for the ICD-10 transition. And then just start overseeing the execution of project tasks. So start, again, picking off those different tasks, getting them done, and then you're ready for go live. And then another important part of your project plan is what you would do to monitor how things are going once you go live. So those are the overarching themes for best practices for creating a project plan.
Well, thank you for going over the project plan. What are some other things that providers need to be doing to get ready?
A lot of different things that will happen between today and October 1st, 2014, as well as beyond October 1st, 2014. So, some of the overall things, and I won't read off every item on this particular slide. As Brian mentioned, you'll be able to download the slides after today's webinar. But, start your provider training today. That's one thing that, we know the providers are very busy. We know that they have a limited attention span a lot of times, and in these particular cases, it's a really good opportunity to start now and look at what are the ICD-10 codes that you typically document for and code for, and then map those over. Find out how they map over into what ICD-10 codes, and then look at what level of detail and specificity needs to be captured for the clinical documentation today, so that you can start coaching providers to start doing that as an ongoing thing, so that when the transition actually comes, they're already doing it. Reach out to your vendors, understand what their plans are, and schedule time for any system changes or training or go lives that you might need to have with your different external vendors. Take the time to document changes to policies and procedures as well as job responsibilities, and make sure that you communicate that to all of the people that are impacted by it, which is very important. Train, train, train. Start training today and keep training. But it's also important to keep in mind that some of your training may be best provided closest to go live. For instance, training coders.
I was curious about that. Why do you say that?
It doesn't make much sense to train the coders today on how to, actually interpret the documentation and assign the different codes if they're not using it today. They're not going to be actively using it realistically until October 1st of next year. So it's something that is daunting. It is complicated to learn, but best to learn closer to the go live so that it's fresh in their minds, and then they're actively coding in ICD-10 once that day hits.
That makes sense.
Okay.
Well, let's pretend that we've reached that point then, that it's October 1st, 2014, and so now the moment has come. What are things to keep in mind about that?
The first thing, again, going back to unrealistic expectations, is, the date is here, now what? Don't expect things to be butterflies and roses, but if you have a strong project plan and everyone within your practice knows what you've done, what changes are happening, how their job is impacted by somebody else's, or how their job impacts somebody else's, those are all good things that help the practice be prepared. So if it's October 1st, you're essentially going live on October 1st, 2014, submitting claims with the date of service 10-1 or before. You need to still be submitting those in an ICD-9 format. So what's interesting is, for a period of time, practices will need to be submitting claims in a dual, I don't want to say a dual format, but they'll need to be submitting claims before 10-1, date of service, in an ICD-10, not ICD-9 format, and after October 1st, date of service, they would submit those claims in an ICD-10. So, that's just another thing to make sure that your PM and EMR vendor is able to accommodate that dual coding. And most, I would say 99.9% of vendors are, unless they're planning to go out of business. I would look at that as a big red flag. But very important that, however you're submitting your claims, depending on the date of service, the key thing when you go live is to be monitoring everything. So all of those different impacts that you identified in your impact assessment you plan for in terms of tasks in your project plan, those are all things that you've made changes to that are now in a new, they're all working in an ICD-10 format. Those are all things you want to keep an eye on. So how are they working? Are there challenges? Are there successes? And being able to, where there are issues, being able to identify those quickly. Again, we talked about moving those up through a determined decision-making chain, making quick decisions on how to right a ship that's gone awry, and make those improvements and do that quickly. And measuring successes, and that's very important because this is not intended to people. It's just intended to say planning will help you mitigate some of the risks, set expectations, and have you better prepared for go live and any issues that might come up, and being able to monitor those. So look at your successes. What's going well? Share that with everybody so that they know, and everybody gets a better sense of, we really worked hard for this, and these are all the things that are working good. But not necessarily looking at the challenges as failures. Those are your opportunities to fix whatever's wrong. So just keep an eye on what's going on, and that becomes your areas that will help you identify where you need to continue training. So do you need, more coding training? Do the clinicians need to be documenting differently? So that's where, when you go live and you monitor everything, that gives you an idea of, what's working well, what do you need to improve, and then if you need to improve things, how do you do that, either through training or procedural changes or something else.
Yeah, I think in many cases people are going to find that they're going to need to go ahead and do additional training after the launch as they identify problems they just weren't aware of before.
Absolutely. And the only way you know that is by, not sticking your head in the sand and going, oh, we have a problem. The key is, don't stick your head in the sand. Look for the problems, try and address those, and move on, and keep an eye on them. But I call it the lather, rinse, and repeat theory. It's continuous improvement. It's just always monitoring what's going on in your practice, and that goes for anything, but ICD-10 in particular, because this does have such a big impact.
Well, we're running a little short of time, but we still have some time left. Let's run through the rest of the slides then. What should providers expect from their practice management and EHR vendors?
So from that particular side, and if you imagine this for any of your external vendors that you might need to be working with, your lab companies, any device companies that connect into the PM and EMR, your vendors are preparing. Again, unless they're going out of business, they have an ICD-10 plan. They should be able to share that with you and talk about what they're doing and kind of give you an expectation of timing and an expectation of what you're responsible for on the practice side for the go live. So ask for their plan, understand what tools, resources, and support your vendors will have available. Make sure that your vendor has contact information for you. I can't stress that enough. We stress that with our clients. The best way that we can reach out in mass to our clients is via email. So we need an email address on file for the key project champions for ICD-10, as well as anyone else in the practice that would need critical operational information about ICD-10. Understand with them how and when they would be testing systems and assisting practices with training on the PM and EMR software changes, and then what ongoing support would your vendor be offering. They could have special consulting packages that you might be able to purchase that they will assist you in monitoring your success with the ICD-10 transition, or training programs that are over and above any standard or required training you might need to have for ICD-10. So those are some of the things to look out from your PM and EMR vendors.
You've identified some resources for our audience that I think would be very helpful for folks. Could you just briefly describe some of what you've got here for us in terms of additional resources?
Sure, and these are just links to some of the key organizations that are very finely in tune with the changes that ICD-10 will bring. Our website is up there if you have any interested in any information on MicroMD, PM, and EMR. Feel free to go there. CMS has a great ICD-10 site. The link is there. AHIMA, the WEDI group, AAPC, all three strong organizations in ICD-10. So visit their websites, tool around, see what resources they have available, what tools. Many of them offer some very nice guides. Admittedly, the CMS guide that they have available on their website for small to mid-sized practices and how they can help prepare, a lot of the information I learned from learning from them. So it's really good to visit those resources and see what's available.
Well, and CMS provides great resources if you can track down where they're located. Sometimes that's the challenge.
Sure.
And then that last URL on the screen there, that's the code translator you mentioned before, where you can, I know that in many cases there's not going to be a one-to-one match, but that might be a good place to at least start to explore how the codes would translate.
Yes, and another thing to look at too is the GEMS codes that CMS offers. And again, not being a professional coder, I don't know exactly how they work, but I've, in talking to other coders, that will be one of their go-to sources for assistance with mapping ICD-10, ICD-9 codes over to ICD-10.
Well, we don't have a lot of time for questions today, but we do have time for one, I believe, and I'd like to remind our audience that any of your questions that we didn't get to, we will be sending out written answers to those questions. But let's go ahead and address one in the time we have left. So we've heard there's going to be many denials of claims. Any sense of how likely this is and what people can do?
Highly likely. And the recommendation is be using a clearinghouse, a strong clearinghouse that has reassured you that they will be ICD-10 ready, and that clearinghouse understands exactly with each of their payers what will be required. But I think it's important to connect with your clearinghouse to make sure that you understand, for all of the different payers that you might work with, what some of the quirks might be that they're aware of in coding and claim submission to make sure that those are not rejected. And work with a strong clearinghouse that gives you strong claim management tools. They give you, giving you clear rejection reasons in real time and good reporting to be able to see what's rejected why and be able to edit your claims quickly and then resubmit those quickly as well. So having those clearinghouses integrated, a clearinghouse integrated with your practice management system tends to be some good tools there for you.
Well, and I have to think that part of it, too, is going to be a matter, or at least for some practices it might be, a matter of cash flow planning, in the sense that if you do have this couple of months of chaos, you really need to think through what's going to be involved in maintaining proper cash flow and just being ready for that, I guess, is the overall takeaway.
Right, and that's absolutely correct. But unfortunately, to be able to put a number on what percentage of claims might be rejected so that you know how much cash flow to have on hand, again, some of it ties to the payer readiness, it ties to the staff training, it ties to how well encounters have been documented to actually be able to, assign an appropriate code for it that will get paid for. There's so many different variables. I wish I had a crystal ball and an answer.
Right, that's truly the billion-dollar question that everyone would like to know the answer to. So.
Yeah, and $1 billion is probably the right answer.
Well, I want to thank our audience for their questions. Again, we will follow up with written answers to the questions because we have limited time. So look for a post with those answers delivered via email later in the week. I'd like to thank you, Kristen, for joining us for today's Iron Lunch.
You're welcome. Thank you.
And again, anyone who would like to learn more about Kristen and Henry Schein's MicroMD solution and the services they can provide, please visit www.micromd.com. I would also like to thank all of our attendees. Remember that all registered attendees will receive an email with links to both recorded and PDF versions of this session, so you'll get those slides for your review. For comprehensive training in meaningful use, register for Formed Approved's new Certified Meaningful Use Professional course. The course covers the requirements for both Stage 1 and Stage 2 of meaningful use for both eligible professionals and eligible hospitals on the Medicare and Medicaid incentive programs, along with clinical quality measures, HIPAA considerations, and more. Visit formedapproved.com/education/courses_CNUP.html. You can see the URL on your screen there to register for this course or learn more. You can learn about our other training offerings at formedtraining.com. On the subject of meaningful use, we've got a hot topic on that subject, a hot presentation on that one tomorrow. You visit formedapproved.com to learn more about our upcoming Learning Lunches. The Learning Lunch button will take you to our entire slate of upcoming webinars. Tomorrow's webinar, July 24th, will cover the subject of how to prepare for Stage 2 of meaningful use. I'm sure there's many folks out there that are really pondering that question themselves. Keep an eye on your email box on our homepage for other upcoming topics, and thank you again for joining us today.